Hi, everyone. So today we are going to be discussing uh, Chapter 13 from your readings this week, Patient Abuse. Now, I want to be cognizant of the fact that this is a difficult topic to discuss, and cognizant of the fact that it's very possible that there can be some triggers in this lecture and in this reading. Um, Trauma triggers if you've experienced abuse or someone you know has experienced abuse. So I just want you to be aware that this is a very sensitive topic, and I'm aware that you might need to do some additional just self-awareness and self-care through this lecture, as I know that it can be triggering if anyone's experienced or is familiar with abuse at a personal level. So I do want to start this lecture with that acknowledgement. So I wish this was a topic we didn't have to talk about. I wish that we didn't encounter these situations ever, let alone in healthcare. But unfortunately, we as healthcare professionals often come across patients that are being abused and victims of abuse. And so we have to be aware of the situation and be aware of how to um, observe that and what to do when we do observe it. So, patient abuse, off of your definition in the readings this week, refers to the mistreatment or neglect of individuals in the healthcare setting. Abuse often happens to those most vulnerable and dependent on others for care. That's why you'll see this week's reading really deals primarily with children and seniors, senior adults, because those are two patient populations that are very vulnerable because they are dependent on other caregivers for most of their needs, right? Children are not independent yet, and senior adults are often not independent anymore. And so they often rely on, for children, it's often their parents or some other caregiver. For parents, or I'm sorry, senior adults, as parents, they're often relying on their children for care or other family members. So that's why those two patient populations are the most common patient populations at risk for being victims of abuse. So this week, we're primarily talking about two patient demographics that are most at risk for abuse, and that's child abuse. CPS is the governing body that works through investigating those situations, and then senior abuse. APS is the investigating body that works through those situations. But you'll notice that senior abuse, it only applies for individuals that are 60 years or older. So as we're going to talk about here in a minute, there is a serious gap for patients who don't fall in either of those categories on what to do when they experience abuse as well. So that's why we're going to talk about these. These aren't covered in your book or this week's reading, but I still felt like they were really important because there are patients that are abused that are neither children or 60 years and older. And so there isn't a specific governing body that deals with that in between, that gap between the two. So it can be difficult to know what do you do when you have a patient in that middle category, in that gap that isn't covered by CPS or APS, but is a victim of abuse. What are some things we can do in those situations? And this sort of related tangentially is those, it can be rare, but it happens enough when the patient themselves is abusive to staff and healthcare professionals, um, and what to do in those tricky situations when we have those kinds of patients. Okay, so those are two topics we're going to go over in this lecture that aren't necessarily covered in your readings. Let's start with child abuse. So an abused child is one who may have suffered intentional, serious mental, emotional, sexual, and/or physical injury inflicted by a parent or other persons responsible for a child's care. every state has some particular nuances about what child abuse includes. So it's important that you look at whatever legislation is specific to child abuse within your particular state of practice, because these are all going to be, whatever's included in that legislation is going to be things you are, required as mandated reporters to report. So some states include starvation, some states include moral neglect, some states include immoral associations, but not all. So you've got to see what's specific to your particular state. So every child abuse definition is a little different legislatively, but it's important to know that children can be victims of abuse by not just their parents, right? It's anybody responsible for the child's care. So think here also babysitters, think here teachers sometimes. I mean, it is anybody, any person who is responsible for the child's care. It can be other older children that are responsible for the child. You've got like a 17-year-old brother who's responsible for his siblings, things like that. So child abuse is not just by parents, it's not just by adults that are biologically related to the child, it's anybody responsible for the child's well-being and care. Things to think about. And then this week's reading gave a lot of very helpful, very sad but helpful statistics around how often and how common child abuse is in the US. I thought it was particularly interesting in that statistic they gave from the study in 2016 that neglected children that were neglected encompassed around 73.7, so 3/4 of victims, and then the other two were sexually abused, physically abused. It's very possible that sexually abused children, physically abused children, that's a pretty explicit, maybe easier to note kind of child abuse, right? When there's physical abuse, there's probably bruises, broken bones, some kind of marking. Maybe there's not, but there often is. Sexual abuse providers are trained specifically on how to observe that a child has been sexually abused or note the behaviorals that can accompany sexually abused children. But neglect is kind of this gray area that is kind of all encompassing, right? Like, what does it mean to neglect a child? So I am actually a certified foster care parent, and your co-professor, Dr. Alex Perry, is also a certified foster parent. And both of us have seen that there's a lot of the children that come in through the system come through with concerns of neglect. And that can be a lot of different things that you might not think of initially are neglect. So, for example, thinking about a child that has diabetes or is diabetic, and part of being a responsible caregiver to that child is ensuring that they are getting the medication that they need for their diabetes and that they are not dietarily or with their diet not taking in foods that will exacerbate their diabetes and may actually cause to a life-threatening event, right? And I can recall of situations in which children with that condition, right, were brought into the system because the parent was either not giving them the medications they needed or not watching their diet at all and letting them have whatever they wanted, which was leading to life-threatening events very consistently. Or thinking about children who have a particular medical diagnosis or condition and their parents aren't taking them to any of their doctor's visits, any of their getting their medical needs met, that's neglect as well. That's also considered child abuse. So there's so much variation. My point in bringing this up is there's so much variation in what neglect can encompass that I think when we think of child abuse, automatically think of physically abused children. We automatically think of sexually abused children. But there is this gray area that's included, that's neglect of children that we also need to be alert and aware of, for children not getting the things that they need to to have well-being. Okay, so we're going to move on now to senior abuse. Senior abuse is the harmful treatment of older people, which includes abandonment, emotional, financial exploitation, theft or misuse of seniors' finances and property, verbal, mental, sexual, physical abuse, corporal punishment, and involuntary restraining or seclusion. So it's interesting to me, there are so many different ways in which seniors can be abused. And that's often because they are sort of in that interesting age of life in which they have significant finances sometimes, right? They're retired, they've got their pension coming in, they have their home that they've lived in for several years. So they have several assets, and can be very financially stable at times. And yet, they're being taken advantage because of all that by people that should be really caring for them and that they trust and should have a trusting relationship with. So there's a lot more ways and mechanisms in which seniors are abused or victims of abuse. Interestingly, though, according to our readings this week, as you'll read, senior abuse is less likely to be reported than child abuse. So even though there's potentially many more ways in which seniors are at risk for abuse, that type of abuse is much more less likely to be reported than child abuse. I just want us to sit with that for a little bit and ask ourselves why. Why do we think senior abuse is less likely to be reported than child abuse? When I think of why, I often think about those very sad situations in which the abuse is happening between a senior adult and their child is taking advantage of their parent in some shape or form. That's a tough spot to be in because I think as a parent, you don't ever want to get your child in trouble. A lot of these seniors don't want to tell someone that their child is taking advantage of them. It could be a point of pride for them. It could be a point of shame for them. Or it could just be a point of them wanting to protect their own child, even though their child is abusing them. So those are very tricky situations to be in. Um, and I think that there's a serious discomfort, for healthcare professionals when they see seniors being abused, but oftentimes have the capacity to seemingly seem like they have the capacity to take themselves out of those abusive situations. So I think of a particular of cases in which patients that are seniors have capacity, meaning they have the ability to make their own medical decisions and carry on their decisions in life with their finances and everything. Um, and they're being abused by their children. I remember a situation in which a lady in her late 70s was being taken advantage by her son who lived with her in her home. Her son was doing illegal activity in the patient's home and posed some serious barriers to the patient when we were trying to create a care plan that included the patient's home, such as home health care, things where the patient was going to be receiving medical care in the comfort of her own home. The son, it got to the point where the son was threatening to bar the patient from her own home, not let healthcare professionals in, um, and was very obviously taking advantage of the patient's financial situation. So you have the situation where the patient knows what's happening. She doesn't have dementia, she doesn't have some kind of cognitive or memory impairment. She's very aware of the situation, knows what's going on, and you would think, as so many of us often do, she should help herself. She should take herself out of this situation. She should kick her son out. She should, keep him from coming in the house, tell him to find his own place, and prevent him from, exploiting her finances. So much more easier said than done. And in reality, there's so many intricacies of family dynamics, relational dependence, that happens in families that we're not familiar with or aware of when we're seeing this as in a healthcare setting. Um, and there can be so many reasons why she's chosen not to do any of those things. She could be afraid of her son. She could be worried about what happens if her son retaliates if she kicks him out, right? There could be endless reasons for why this patient decided not to take herself out of an abusive situation. But our responsibility when we see this and when we witness that is to report it, right? That's our obligation. And so I think that's one of the reasons that senior abuse is less likely to be reported than child abuse, because it feels like it's a grayer area. Like these seniors, especially when they're competent to live their lives and make their own decisions, seems like they should be responsible for taking themselves out of these situations. But that's not what the mandate's about, right? The mandate isn't about the capacity of victims to be taking themselves out of situations. It's about our responsibility to report any suspicion of abuse. Um, so I think that might be one of the reasons. And of course, that very unique relationship between parents and their children, when it's the parent being abused by the child, that can feel tricky, especially for the parent to report that they're being abused. And so it can't just be like a lack of knowledge because they're not showing or telling us that they're in an unsafe situation. So very sad cases to witness in healthcare. And then I did want to cover just briefly patient abuse that's not covered by CPS or APS. On page 353 in your readings, you'll see 1 in 2 homes in a particular book. It was a study that was done, was the scene of a family violence at least once a year. That's striking. The quote on that page says, "The American home are perhaps as much or more violent than any other single institution or setting," which I think is just devastating. Homes are supposed to be a safe space. They're supposed to be a safe environment, and this study and this reading this week is really showing us that is more often than not the case. A lot of family members are in unsafe environments in their own homes, unsafe situations, and some of that spills over when they receive healthcare professionals, for healthcare services, because we witness or see glimpses of that, glimpses of what's happening at home in a doctor's visit or in an acute care setting. So it's challenging when we see patients that are neither children nor 60 years and older endure abuse, because there's not a specific organization that is in existence to deal with these situations. But call law enforcement, um, get your local law enforcement involved, and put it in their hands to investigate and make sure that that if possible, these patients or these situations can be resolved and these patients can be in safer environments. Okay, so reporting. All of you are mandated reporters. Healthcare professionals are mandated reporters. Um, you're reporting based on the existence of signs of abuse and maltreatment in light of your experience and training, which, by the way, this course, this class, this particular lecture is part of that training experience. So anything that you've been trained and experienced in can really assist in helping you be more aware of signs of abuse. And you're reporting on good faith belief, which is just the fact that you're reporting facts that you believe are true. And that's what good faith belief reporting is. That's really sort of the only, um, just kind of the foundation of reporting, is making sure that when you're doing so, you're not doing out of malice or anything like that. You're doing it because you believe the facts, your suspicion of the facts of the report are indeed true. So criminal and civil risks for healthcare professionals, don't lie and do not lie in good faith reporting, right? Just because, if you have a sense, you feel like something just isn't right, report it. Don't think I need to have all the facts. I need to look into this a little more. I feel like I don't know what's going on. I probably need to ask more questions. There's a lot of questions that aren't answered. You don't have to have the whole picture. Any kind of suspicion that there is abuse going on, report it. The criminal and civil risks for healthcare professionals lie in failure to report, not in over-reporting. Failure to report, not over-reporting. So I always say, if you have a hunch, if you feel like something's not right about the situation, report it. Because APS, CPS, law enforcement, they will go through their process of looking into it and seeing what's going on. No one's going to go barring through someone's door as soon as you call them, right? Nothing's done in a haste, unless they have significant evidence to to think that that's the appropriate response. Most of these things are investigated. They're looked into further. There's calls being made. There's things being looked into, bank statements even sometimes. So they're good at what they do. Our obligation is just to report it to them so that they can then go ahead and look into it further. And then this is sort of that side topic I felt was related. Sometimes patients are abusive. Sometimes patients are not the ones being abused. Sometimes they are the ones abusing. And it's important to note that abused people abuse. So it's very possible that abusive patients were abused at some point in their life, and so they're very familiar with this way of behavior, of behaving towards other people, of being abusive, of saying awful things, of hitting, of slapping, things like that. So start by setting clear and distinct boundaries with patients. This is okay, this is not okay, this is what we expect from you when we're providing care, when you're receiving care. This kind of language is not appropriate, this kind of behavior is not appropriate. Set clear and distinct boundaries with patients, because you really can't expect patients to know what's appropriate. Never make the assumption that common sense is common, because common sense is very relative. Um, we just all come from different walks of life. Everybody does. And so it's important that you're setting clear and distinct boundaries of what's appropriate when patients are getting care. Um, Follow your chain of command in reporting when incidents come up, and talk about strategies. So if all of you will have some kind of supervisor, I imagine. So make sure that you're not waiting till this really exacerbates and becomes a massive issue. At the first mention of something inappropriate, the first anything that just isn't, you don't feel is right, you're not comfortable with, report it to your chain of command, report it to your supervisor, because you want that support to know what to do, and they will have better instructions on what to do in that situation. And then thinking about strategies, you might need to think out of the box. We've had situations where it's a gender thing for whatever reason, where patients are particularly belligerent when it comes to male staff, or particularly belligerent when it comes to female staff. So maybe change the staff personnel. It's not an ideal situation, but sometimes that's what's required. Look at maybe behavioral contracts. There's some research in that. Studies show that they're not super successful, but sometimes that looks like, saying this is what we expect of you as a patient while you're getting care, and this is what is not acceptable. If you don't comply with these expectations, XYZ happens, and then they sign. And that's what a behavioral contract is. They're not super successful in accomplishing change in behavior, but sometimes it makes providers feel better. But there's a lot of reading and study out there that I recommend you look into about behavioral contracts and sort of the ethics of that. The other thing to think about is behavior as a symptom. So maybe there's a diagnosis we're not aware of, or there is a diagnosis like dementia that might be contributing to the behavior of a patient and looking into whether there is a specific medicine or change in their medicines that could help with this particular behavior that they're exhibiting. And then lastly, if nothing is mitigating the situation, you can dismiss the patient and refer them to another provider. There's no guarantee that another provider is going to take them. We've had lots of patients that have behavioral issues that are fired from facilities, from various specialties. They won't take them anymore because of this history of being belligerent and misconduct. But the obligation is just to see if you can refer them to another patient. If there is, I'm sorry, another provider. If there is another provider that's willing to take them, that's kind of the last resort. But again, follow your chain of command. They will be able to tell you how soon a dismissal is appropriate and when to go through with that. All right, so that concludes our lecture for this week. I want you to take away, if nothing else, the fact that you do not have to be certain or prove that there is abuse happening. It's not your job to prove that a patient is a victim of abuse. It's your obligation to report any suspicion. And there really is no there's no consequences to over-reporting. In fact, sometimes, even when it's something small, you need that kind of case build, because anytime a report is filed on a particular individual, APS or CPS or law enforcement, they'll keep a file of reports, and it just builds sort of the case and the fact that something's not going on here. There's a pattern. We keep getting we keep getting reports. We keep getting sort of calls about this person potentially being a victim of abuse. There must be something going on if we keep getting calls from different people. So always call if you have suspicion, if you have concern, if you have a hunch. Always call with the information you have. Those investigative bodies, they will look into it further. That's their job. So happy reading, and I'll see you at the discussion board.